Dimitri Daskalakis. I'm the Deputy Commissioner for Disease Control at the New York City Department of Health and Mental Hygiene. And today I'm going to give you an update about novel coronavirus or COVID-19, and it's a primer for healthcare providers. An important disclaimer is that our understanding of this virus is changing rapidly, and this presentation is based on our knowledge as of March 18th, 2020 at 10 a.m. Briefly, the outline of this talk is we'll talk about where we are with this outbreak, give you some background, give you a status of the outbreak, some clinical features, give you some important guidance that has changed for healthcare, talk about mitigating community transmission in the United States and in New York City, give some more guidance for this pandemic, and then ultimately land on additional trusted resources. So where we are. As you all are aware, we are in the midst of a global COVID-19 pandemic. There is widespread community transmission in New York City and beyond. Over the next few months, a large proportion of Americans and New Yorkers will get sick with COVID-19. Our healthcare system will be tested as it never has before, but together, as New Yorkers, we can and must slow the spread and protect those at higher risk of severe illness and our healthcare workers from getting sick. We have shifted into an era where we are working to mitigate the impact of this pandemic virus. With no intervention, one would expect a fast peak of very ill individuals entering healthcare, very quickly overwhelming our ability to admit them and also give them higher level care in the ICU. Many of the efforts that you've seen in New York City, including the cancellation of large events, closure of schools, all of those are part of a mitigation plan. The goal of mitigation is to reduce the peak of this outbreak and reduce the peak of the pandemic. So at any one time, fewer people are seeking care because they're ill. Fewer people are requiring ICU beds or hospital beds. We will still see a number of individuals greater than what the capacity is of healthcare. Our job as healthcare professionals will be all hands on deck to work through this, to get through the outbreak as it continues to evolve. I'll remind you that COVID-19 started as a small outbreak of respiratory illness in Wuhan, Hubei, China in December 2019. We first heard about it when there were 40 cases with a history of exposure to a live animal market, quickly suggesting the possibility of animal to human transmission. Scientists in China rapidly identified and sequenced the novel coronavirus. The virus was named SARS-CoV. The syndrome is called COVID-19 or COVID-2019. And SARS-CoV-2, the virus, causes the syndrome we call COVID-2019. I will be referring to this as COVID, interchangeably virus and syndrome. Coronaviruses are a family of viruses that we have been aware of for decades. Animals and humans can be affected. There are many common strains that can cause upper respiratory tract illness. There are some, however, that are known new zoonotic transmissions that cause more severe illness in some circumstances. SARS-CoV emerged in 2013. We have not seen cases since 2004. MERS-CoV emerged in 2012. Cases continue to be reported in other parts of the world. And SARS-CoV-2 emerged in 2019. And the outbreak is ongoing. This outbreak is global. It is a pandemic. There's widespread human-to-human transmission. Greater than 200,000 cases have been reported, greater than 8,000 deaths, and over 150 countries and territories are reporting cases. Sustained community transmission has been noted in several countries. The list is too long to name. The United States is among the countries that has sustained community transmission, and New York City is among the cities that has sustained transmission in the community. All 50 states now have confirmed cases. As I told you, there is community transmission in multiple states, including California, Oregon, Washington, and New York. This number is actually out of date as of this talk, but as of 3/17 at 2:30 p.m., just over 800 confirmed cases were identified in New York. Many more have been identified elsewhere in New York State. It's also important to remember that many people with COVID-19 related illness have not been tested and are not reflected in the data. We will talk in detail why testing must be reserved for hospitalized patients only. Outpatients should not be tested for COVID-19. There's very important observations in terms of our group of patients that we've identified in New York City. The majority are over 18. Most are male, about 58%. And we're seeing transmission in all boroughs, with Manhattan and Queens being the currently most represented. Many of these patients have required hospitalization. Many have had underlying illnesses, and a high proportion are admitted to the ICU. We have, at the time of this talk, report 6 deaths. We expect that number will continue to climb. We'll move on to clinical features. The incubation period for COVID-19 is about 5.2 days. The range is 2 to 14. The median patient age reported in China is between 49 and 56 years old. There are non-specific initial symptoms, most commonly fever and a dry cough, less frequent but present myalgia, headache, sore throat, and occasionally diarrhea. Transmission is thought to be mainly via respiratory droplets, less commonly from direct or indirect contact. There is no evidence of airborne transmission to date, and scientists are still debating the role of fecal-oral transmission in COVID-19 disease. Certain individuals are at higher risk for the more severe outcomes of this infection. That includes folks over 50 years of age, as well as individuals with chronic medical conditions like cardiovascular disease, diabetes, chronic lung disease, or an altered immune system. Cancer is also a risk factor. Severity of early laboratory confirmed cases in China really show us that even though we will have many people who are infected or have symptoms, about 80% of them will have a mild to moderate experience. 14% will move on to a severe disease with dyspnea, hypoxia, tachypnea, and potentially pneumonia or lung infiltrates. 6% will have a need for critical care support, meaning respiratory failure, shock, multiple organ dysfunction. The case fatality rate in China is 2.3% with a range of 0.6 to 3. There are some laboratory findings that are suggestive. None are pathognomonic for this infection. They include lymphopenia, 70%, prolonged prothrombin time, 58%, elevated LDH, 40%. There's also radiologic features that are consistent with COVID-19. Bilateral patchy infiltrates are often seen on chest X-ray, and chest CT shows what you would expect from any viral pneumonia with ground glass infiltrates. I will talk a bit about some case studies from China. As we are learning more about our cases, we will be very transparent and share information. In one case study of 138 individuals in China that were hospitalized, 54% were male. Median age range was 56 with a range of 22 to 92. Importantly, hospital-associated transmission was suspected. 40 healthcare workers and 17 patients. The belief is that it was through nosocomial hospital or healthcare-associated transmission. Chest CT showed that 100% of these cases had bilateral ground glass opacities, and 36 of them were reported transferred to the ICU, 61% with ARDS. The median age was 66 years old, and over 70% had underlying comorbidities. Signs and symptoms at presentation were fever, dry cough, and fatigue. And again, lab findings, lymphopenia, prolonged PT, and elevated LDH. In a larger case series of over 1,000 patients, including hospitals beyond the Wuhan area or the Hubei province, they show the median age range of 47 years old, 42% were female, 5% were admitted to the ICU, 2.3% required mechanical ventilation, and mortality was 1.4%. Cough was common at presentation and diarrhea. Some did not come with fever, but during their course developed fever. So 44% on admission were afebrile and 89% as inpatient at some point developed a fever. Ground glass opacities were seen on CAT scan, over 50%. And it was clear that individuals with more severe disease had these changes. In terms of prevention and treatment, both vaccines and treatments are under development in US, China, and elsewhere. Our only support now is our only medical care that's an option is supportive care. There's no specific therapeutic that treats COVID-19. An important recommendation is to avoid corticosteroids unless indicated for other reasons. Remdesivir, a drug that is currently under study, is being looked at as potentially an experimental treatment. There are criteria for compassionate use from the manufacturer Gilead, and they are that a confirmed infection, pneumonia, and hypoxia would allow you to potentially access this drug, but exclusion criteria include a creatinine clearance less than 30 mils per min and LFTs over 5 times the upper limit of normal. Clinicians can directly reach out to NIH or Gilead directly, and there's some information on how to at the web addresses that are listed on this slide. On to guidance. So we are providing you up-to-date information, posters, and other clinical resources. You should go to our provider page. The website is there. We also, for medical providers, have the option of our provider access line, 866-692-3641. It's 24/7 and allows for consultation with a public health expert. We also continue to provide updated guidance via Dear Provider letters and through our Health Alert Health Advisory Network. Additionally, we present webinars, sometimes by ourselves and sometimes with the state. First, let's talk about the Health Advisory Network. Health Alert number 6, COVID-19 updates for New York City. Health Alert number 7, which is new, is showing guidance for healthcare workers self-monitoring and work restriction in the presence of sustained community transmission of coronavirus disease, and is supplemental information beyond the very excellent guidance of New York State for individuals and how they can return to work. In terms of general facility preparedness, it's important that you maintain awareness, regularly inform staff regarding current status of the outbreak, and disseminate our New York City Department of Health alerts and advisories. Tell people with moderate or mild disease consistent with COVID-19 to stay home and not to go to the healthcare facility. Repeat, individuals with mild or moderate disease should not come to healthcare. They need to stay home. They do not need to be tested. Testing creates a scenario where individuals interact with healthcare unnecessarily. ERs must be reserved for only the severely ill. Implement and adhere to policies and practices to minimize exposure to respiratory pathogens, including SARS-CoV. Maintain a continuum of infection control measures before and throughout the patient visit and until a room is cleaned and disinfected, and protect those at increased risk for adverse outcomes for COVID-19. There are some very important pillars of preparedness. 1, identify. 2, isolate. 3, inform. So first, identifying people with potential COVID-19. Ask patients with COVID-19-like illness to call ahead when possible so you can prepare for their arrival. This is a great time to use your patient portal. It's a great time to use the phone to see if you can manage individuals without bringing them into healthcare. It protects your healthcare workers, protects you, and also protects the patients. Place signage and greeters at entry points to screen individuals for COVID-like illness. Once identified, it's important to move quickly. Triage personnel should use face masks and tissues to be able to distribute to these patients. It's important to develop source control immediately, even before we even suspect a COVID infection. If someone has those symptoms, put a face mask on the symptomatic patients. For now, that's how we're going to recommend it. In the future, as we see more and more COVID cases, cohorting of symptomatic individuals may be necessary if face masks are in short supply. The next step, is to isolate. You have to evaluate the patient in a private examination room with the door closed. Please note, an airborne infection isolation room is no longer required unless the patient is undergoing aerosolized generating procedures. Important to remember, collection of a nasopharyngeal or oropharyngeal swab is not an aerosol generating procedure. If a private exam room is not available, identify a space where patient can be separated from others by at least 6 feet and with easy access to respiratory hygiene supplies. In some settings, have the patient wait in their personal vehicle or outside the facility and call their cell phone when you're ready to attend to them. Patient rooms do not need to be left empty after patient leaves unless aerosol generating procedures were performed. Personal protective equipment. Protecting healthcare workers is our top priority in New York City Department of Health. Per new CDC guidelines, patients can now be managed with droplet precautions. Note, droplet, not airborne precautions. Facilities must conserve N95s and be aligned by messaging to their staff this critical change in PPE. Protecting your supply means protecting your healthcare workers in the future. Use standard contact and droplet precautions with eye protection when caring for patients with possible or confirmed COVID-19. Remember, anyone who has symptoms consistent with COVID-19 should be dealt with as if they are a confirmed case. PPE should include a face mask. That's a procedure or surgical mask, not an N95 for general care, as well as a gown and gloves and eye protection. Healthcare workers do not need a fit-tested N95 respirator or powered air purified respirator PAPR for routine non-aerosol generating care of a COVID-19 patient. On the other hand, a fit-tested N95 or PAPR is still recommended when performing aerosol generating procedures. Some examples are intubation, suctioning, certain high flow oxygenation strategies, and caring for critically ill patients with COVID-19. The New York City Health Department receives positive COVID-19 test results directly from laboratories, so we are informed by lab reporting. Report people who are part of a cluster of 3 or more possible or confirmed COVID-19 cases in a residential setting that serves high-risk populations by calling a provider access line. Testing for SARS-CoV. There is a molecular assay an RT-PCR that's available in commercial laboratories, hospital-based laboratories, and at our New York City Public Health Laboratory. It's important to define first who not to test. Here's what you tell your patients. If they are sick with symptoms consistent with COVID-19, stay home for 7 days following symptom onset or 72 hours after being consistently afebrile without the use of antipyretics and respiratory symptoms are resolving, whichever of the two is longer. Do not test people with mild to moderate illness who can be safely managed at home unless diagnosis may impact patient management. Avoiding unnecessary tests minimizes possible exposure to healthcare workers, patients, and public, reduces the demand for PPE so we can save it for our inpatients who are hospitalized and critically ill. I would like you to think of this. Every unnecessary COVID-19 test that's performed takes it away from someone who needs it, either by the capacity of the lab or by the fact that appropriate PPE will not be available to do the testing. Do not do unnecessary COVID-19 testing. Reserve it only for inpatients. When possible, you may also think of testing patients for common causes of respiratory illness before testing for COVID-19. So if it's the flu, you can stop right there. Now, who should be tested? Testing should be reserved for individuals who are sick enough to be admitted to the hospital. People for whom the provider believes testing will change care or management. I want to walk through this for a second. If you have someone who comes to see you with a fever, cough, and shortness of breath, and you happen to test them for COVID-19, and the result is negative, we would like you to continue treating them as a COVID-19 patient. So briefly, that test didn't help you, so don't order it. An individual presenting with fever and cough during this pandemic who has a negative test should be considered a COVID-19 patient and given appropriate counseling. They should be directed to stay home for 7 days or 72 hours afebrile off antipyretics, whichever is longest. So how do you test? For the people who are inpatients, commercial and hospital-based laboratories are available. We are very interested at the New York City Public Health Lab to get specimens for hospitalized patients presenting with severe acute lower respiratory illness like pneumonia. This still requires pre-approval through us, but if you go through your hospital-based laboratory or commercial labs, we don't need to approve it. There is an e-order account that you can that your lab or you can get to make ordering easier. To get approval, you need to call our Coronavirus Test Call Center, 866-692-3641. And if you don't have an e-order account, visit the Public Health Lab website to be able to get one. If approved, you're going to send specimens to the hospital central laboratory with a PHL assigned unique identification number. The central lab should submit requisition orders via e-order and call back the testing center for transportation if needed. Ordering providers are responsible for giving patients results. Repeat, the lab will not be giving patients results. Ordering provider will be responsible. In terms of how to get the specimens, collect one NP and one oropharyngeal swab and then pack it in the same viral transport medium collection tube. One more time, NP, OP in the same viral transport collection tube. One lower respiratory tract specimen like a sputum can also be submitted if it can be easily collected. Bronchial or tracheal aspirates in patients on ventilator supports are also acceptable. How do you discharge a patient? Patients with confirmed or possible COVID-19 who are being discharged should be told to self-isolate. That applies to patients being discharged from the emergency or inpatient department or being sent home from an outpatient healthcare facility. Household contacts should be reminded to self-monitor. The New York City Health Department does not require a negative COVID-19 test to release a patient from a healthcare facility. Tell the patients, stay home and self-isolate for at least 7 days after symptoms started and fever-free for 3 days without the use of fever-reducing drugs. It's the same message as before. What about healthcare workers and self-monitoring? Healthcare workers who are currently furloughed because of exposure to possible or confirmed COVID-19 cases may return to work if asymptomatic. All healthcare workers are at risk for unrecognized exposures. All healthcare workers should self-monitor for illness consistent with COVID-19, since it's necessary that we all act as if though we are exposed. Self-monitoring means taking your temperature twice daily and evaluating yourself for COVID-19-like illness, which includes the onset of any of the following: a temperature greater than 100 degrees Fahrenheit or 38 centigrade, or subjective fever, cough, shortness of breath, or sore throat. If known high-risk exposure to a patient with confirmed COVID-19, also check for muscle aches, malaise, runny nose, stuffiness, or congestion. Guidance for healthcare worker self-monitoring continued. If a healthcare worker develops mild illness, they must stay home and self-isolate for 7 days following symptom onset, or 72 hours after being consistently afebrile without the use of antipyretics and respiratory symptoms are resolving, whichever of the two is longer. Employers may require staff to report temperature and symptoms daily. That's active monitoring, and may have additional guidance for specific employees caring for high-risk populations such as older adults or immune-compromised patients. New York City Department of Health does not require healthcare workers to undergo quarantine or to have a negative test for COVID-19 to return to work. However, at the completion of isolation, healthcare workers should check with their employer before returning to the job. CDC advised healthcare facilities to consider allowing asymptomatic healthcare workers with exposure to a confirmed COVID-19 patient to work while wearing a surgical mask. However, Department of Health again stresses all providers should be self-monitoring and if sick, stay home. Given limited availability of PPE, use of surgical masks by asymptomatic exposed providers at work should be limited to those who have had known high-risk exposures or are involved in care of vulnerable patients. That means greater than 50, chronic lung disease, heart disease, diabetes, or otherwise immunocompromised. Moving on to environmental cleaning. Clean and disinfect room before returning to routine use. Use EPA-registered hospital-grade disinfectants effective against coronaviruses in accordance with manufacturer's instructions. Clean all areas with focus on high-touch surfaces. Treat contaminated waste as routinely regulated medical waste. Follow standard operating procedures for containing and reprocessing used linens. Anticipate supply shortages. Supplies of PPE must be reserved for high-risk procedures due to potential supply chain constraints. Decrease in PPE imports and increased demand will limit the availability of these important resources. Utilizing existing stockpiles, local, state, and federal. Check with trade associations or healthcare coalitions for requests for more of that PPE. Medications and other medical supplies may also be in shortage. Hospital beds, healthcare personnel, ventilators. Plan now for contingency and crisis care in the setting of limited resources. Mitigation. So the initial strategy that most jurisdictions, including New York, had to the COVID-19 pandemic was containment. That means we were quarantining travelers from high-risk countries, identifying cases and contacts and isolating them. But we also had our normal good guidance in any flu season, which is wash your hand and all of the good sort of sneezing and cough hygiene that's necessary to prevent transmission of any respiratory virus. Unfortunately, with community transmission, containment becomes impossible. Chasing one case at a time becomes playing whack-a-mole. So instead, our response has shifted to mitigation. And the goal of that is to minimize spread and then reduce the harm or mitigate impact of this pandemic. Measures to decrease population-wide impact include the standard things that we've been talking about for months. Wash your hands. Use alcohol-based hand sanitizer. Cough in your elbow or into a tissue or into your sleeve. Sneeze in the same way. Don't spread droplets. We additionally have added community-wide measures to improve social distancing. Work from home, telework, stagger work hours. Schools have been closed and unnecessary services, many have been stopped. Limit the use of healthcare by the worried well or mildly ill. If you're sick, stay home. If you're very sick, call your doctor. And if you need the ER, reserve it only for severe illness. Also, this is not the time to gather in large groups. There's a ban on gatherings greater than 50 people. It's a good idea that New York right now just stays home. That's a really important message. Additionally, there's been some movement toward enhanced cleaning procedures in schools and mass transit. But ultimately, the most important message is if you're sick, stay home. If you're well, stay home. Just stay home. So we know that there is widespread community transmission in New York City. We're continuing to look in different ways, but ultimately, though there are some research protocols happening, it is very clear from our epidemiology that we do have widespread community transmission. We continue to see increases in COVID cases, and as you see week by week, it's increasing very rapidly. Through our syndromic surveillance, which means that emergency departments and other settings like urgent care are reporting to us individuals who are coming to care with influenza-like illness. The purple line represents 2019-2020. So you can see that we're seeing a surge in influenza-like illness visits to emergency departments, and the peak is already higher than the peak of our flu season, which was already bad. So we are continuing to see lots of evidence that we have surging cases of COVID-19. Additionally, and very concerningly, we are seeing increases in pneumonia syndromes in the ER. Toward the end of this graph, you'll see a line that is going almost straight up. That is defined as the ratio of pneumonia to total ED visits. So pneumonia is actually a very significant piece of what's happening in New York City and what's keeping our emergency departments very busy. So guidance. All New Yorkers, especially healthcare workers, must act as if they've been potentially exposed to COVID-19. Anyone with confirmed and possible COVID-19 must stay at home and self-isolate. Everyone must self-monitor daily. If you have a fever, cough, shortness of breath, sore throat, stay home. It's important to emphasize social distancing. That means even if you're well, stay home as much as you can. It's also important to not abandon the individual measures. Hand hygiene is important. Cover your cough and self-isolate if you're at home if you're sick. And I mean really stay home. It's not the time to walk around. It's not the time to interact with friends. We need you to stay home and tell your patients to stay home if they're not feeling well. All New Yorkers should practice social distancing. That means, again, stay at home to the extent possible and only leave for essential tasks. Everyone in New York should consider themselves as possibly exposed to COVID-19 and should monitor their health even more than they usually do. Healthcare workers especially should monitor their health very closely. And any sign of illness means stay home. People with possible or confirmed COVID-19 should be instructed to self-isolate in their private residence. Once again, that isolation needs to continue for 7 days following symptom onset, or 72 hours after being consistently afebrile without the use of antipyretics and respiratory symptoms on the way to resolving, whichever of the two is longer. So what do you do now? We have to work on preventing nosocomial outbreaks. Review our guidance. It's updated regularly. Educate and train staff, including training around appropriate PPE. Take stock and protect your PPE and environmental supplies. Create and disseminate risk communication to patients, staff, families, and visitors. More plans for now. Your facility should implement plans now for patient surge. Healthcare staff self-monitoring and incentivizing staff to stay home if sick. Make plans for managing visitors. Make plans for handling staff shortages, contingency staffing, cross-training. I will take that back. Implement your plans for handling staff shortages, contingency staffing, and cross-training. Consider ethical areas of concern during surge. Crisis standards of care need to be considered early, so plans are made to implement them when necessary. Also, work on all of your environmental protocols to make sure that the hygiene of your facility is up to snuff. Other steps to take now. Implement triage protocols. Think of ways that you can evaluate your patients remotely. Can you use video conferencing? Can you use telephones? Avoid unnecessary visits. Give people more refills where possible. Screen at entry for symptoms. Set up alternate sites for COVID-19 triage in your facility. And as inpatient services and ICUs become bigger, start to implement strategies to triage beds and ventilators. Cancel elective admissions and procedures. It creates capacity for individuals who need ICU and higher levels of care. And I'll say it again, remote medicine seemed new to us a few weeks ago. The future is now. Implement telemedicine services now. Some of the regulations around the use of platforms have been loosened to be able to optimize what happens, and reimbursement as well. Please implement these services so you can maintain continuity. We have a lot of places that you can look for guidance and resources. Visit our New York City Health Department provider webpage, the CDC novel coronavirus webpage, and for an up-to-date status on this pandemic, watch the Johns Hopkins daily update case count and maps. If you need to reach us, providers should call our provider access line or PAL, 866-NYC-DOH1 or 866-692-3641, 24 hours, 7 days a week. If you are watching this in New York State, outside of New York City, please look at the web address on this slide. Go to that address and identify your county